Welcome, Mary.
Thanks. Thank you. Can people hear me pretty well in the back? Yeah, great. Okay. I think I'm going to stand up here both so that you can see me and so I can see you, and I'll stay out of the way of the light as well. Never go toward the light, as it happens. So I have been doing this work for quite a long time. I think coming up on 25 years this year since I first started doing research in college drinking prevention. Speaking of the impact of environment, I happen to be fortunate enough to work with Kim Fromme as an undergraduate and with Alan Marlatt as a graduate student. And heaven knows what I'd be doing if I hadn't ended up at the University of Washington to do this, because it's the only thing I'm good at. When I first started doing this research as a naive undergraduate, I was very surprised to learn that college students were not regarded as real people, actually. They were considered to be, at best, a poor analog for real substance use problems, which everybody knew occurred in older, middle-aged populations in the community and did not occur in privileged young folks in college. So there's been an enormous shift in the perception of what alcohol problems are and how they manifest and how they affect young adults, and particularly young adults in college, in that period of time. However, what I'm about to say could have been said then and can still be said now, which is that most campuses have multiple substance abuse and alcohol abuse prevention programs on their campuses. Many of those programs have no evidence of efficacy. Some programs are known to lack efficacy but continue to be utilized, and that evidence-based programs are often reinvented or adapted without evaluation, so therefore we have no way of knowing how much they maintain their efficacy under those conditions. In response to those kinds of statements, NIAAA has really taken a major leadership role over the last 20 years to try to address some of those problems, to build a knowledge base that could be useful for administrators and counselors on college campuses, as well as to propel the research forward. One of those efforts Mark mentioned earlier was the College Drinking Prevention Task Force. They, if you don't know, issued a report in 2002. Everything from that task force, including the original source papers, summaries, links, et cetera, is on the collegedrinkingprevention.gov website. It's a tremendously useful resource. And that was updated also in 2007 with a brief update of what had come out since then. So I was commissioned to write a paper as part of the original task force. And I need to acknowledge my partner in crime, Dr. Jessica Krantz, who has been helping me review this literature and keep on top of it now for over 10 years, looking at brief individual-focused interventions for college drinking prevention, which is what I'm going to talk about today. So over the years, one of the things that has happened is there's been a tremendous increase in the amount of research in this area. There are multiple studies that have looked at various iterations of brief interventions for college drinking prevention. Unlike 20 years ago, there's now very good evidence that some of these interventions are effective and efficacious in reducing college drinking, to a somewhat lesser extent in reducing alcohol-related negative consequences, depending on the particular intervention, how it's implemented, et cetera. So that's the good news. The NIAAA Task Force report broke interventions into four tiers of evidence in support of them, or in lack of support of them. I'm going to talk today about Tier 1 interventions that had evidence of effectiveness among college students in multiple randomized clinical trials. I also mentioned Tier 4, which had evidence of ineffectiveness, and I'll just say that that primarily involved awareness or informational programs in the absence of other skills, motivational, or normative components, which had been shown in multiple studies not to impact drinking or consequences. So at the time of the original task force report, there were three types of interventions that were incorporated into Tier 1. Those were all individually focused, brief interventions. They have a lot of more similarities than differences among these types of interventions. The first was really these sort of multi-component skills training interventions. They combined cognitive behavioral skills training with motivational interviewing or motivational enhancement components. often also including normative clarification or norms correction components, and sometimes including also alcohol expectancy didactic components. It also included brief motivational enhancement interventions with or without personalized feedback. These tend to have many of the same kinds of components, but they tend to be done in a much briefer format, usually one-on-one, sometimes in the absence of one-on-one, just using the motivational feedback itself as an intervention. Sort of a subset of those are interventions that just target perceived norms and try to correct normative perceptions. And then interventions that challenge alcohol expectancies, which you heard a little bit about from Mark Goldman this morning. So beginning with this first, these sort of multi-component skills-based interventions, the kinds of skills or content that these include often include moderate drinking skills like self-monitoring, limit setting, et cetera, blood alcohol concentration, information and education, assertiveness skills, drink refusal skills, et cetera. Can also include sort of general lifestyle management skills like lifestyle balance, exercise, stress reduction, and alcohol expectancy pieces. There are informational components to these interventions. So it's not that these don't include alcohol awareness or information. So for example, it says when they tell you to have just one glass a day, never ask what size on the left. On the right is an actual picture of an actual fraternity where they had a one-drink limit for their parties. This is their drink. Just as a brief anecdote, this kind of information can be helpful in the context of other interventions. I once had a client come in to see me. On the phone screening, they had told the phone screener that they never had, we'd asked them the audit question, how often do you have 6 or more drinks in one day? And they said, well, they never had 6. They thought that would probably kill them. Typically, they never had more than 3 drinks a day, sometimes 4. But he knew he was an alcoholic. So I asked him when he came in, I'm like, I'm kind of a little bit puzzled about that. Can you tell me a little bit about your drinks? And it turns out that each drink was an 8-ounce glass of pure bourbon. And he was right, 6 would have killed him. He was drinking around 30 drinks per occasion. So it does include information about like what is a standard drink and things like that, but those are in the context of building motivation to change your drinking, looking at some of the things you like and don't like about your alcohol use and building skills to change that if you choose to do so. And then using some specific protective behavioral strategies to help reduce harm related to your consumption as well as to reduce your consumption per se. There have been a lot of recent studies looking at protective behavioral strategies. These are one of the things that we've been able to show mediate the effects of these brief interventions. If you can increase the use of protective behavioral strategies, that tends to be related to reductions in use and consequences. These are not rocket science. Many people know how to do these things, but they choose not to do them. Some people would like to do them and don't know how or perceive barriers to using them. What I want to talk about today is what the literature base, what the science base is for these kinds of interventions. And again, I've been reviewing this literature on a somewhat continuous basis since about 2000. The first report came out in 2002, the second in 2007. And we have a paper under review in Alcohol Research and Health right now that is an update from the 2007 report. So this is kind of continuous. There have been, at this point, 21 randomized controlled clinical trials of these multi-component interventions on college campuses that met inclusion criteria for our review, which is they had to have a control or comparison group. They had to have a longitudinal follow-up looking at both baseline and what happened to their drinking after the intervention. We find that that 14 of the 21 had significant effects on drinking, consequences, or both. Favoring the multi-component skills intervention in comparison to controls, and that includes, in some cases, just assessment as a control, and in other cases, these informational or awareness type programs by themselves as controls. And the better the study, the better the outcomes. So the studies that have larger sample sizes, longer follow-ups, better randomization, better equivalence of the interventions at baseline, better assessments show bigger effects. There's also been a study that looked at a multi-component skills training intervention that was done via a parent handbook in combination with brief motivational interventions for the students, and showing that if you combine parent and these brief motivational interventions, you actually get a better effect than either intervention alone. The second type of intervention that I want to talk about is brief motivational enhancement interventions. These, as I mentioned, are similar in many ways. They use motivational interviewing style. The prototypical brief motivational enhancement intervention is the BASICS intervention developed at the University of Washington by Alan Marlatt and some of our colleagues there at the UW. I used to run BASICS interventions as a graduate student, so I've been around the edges of this for a long time and have been developing briefer and briefer versions of BASICS over the past 20 years. The hallmark of in-person brief motivational interventions is the discussion of alcohol use in a motivational interviewing style, meeting people where they're at, helping to build discrepancy between what they're doing and where they want to be, between what they believe and what the facts are, for example, in terms of normative feedback elements, using the basic principles of MI, which I'm guessing most of you are familiar with. If you're not, read Miller and Rolnick. Is a great place to start. John Baer has a book on this. The BASICS book gives a lot of background on that. Most of these brief motivational interventions also use detailed graphic feedback, starting with an assessment. A person does a computerized or in-person or paper-based assessment, and they receive graphic feedback related to that, showing how their drinking compares to the norm, how much they drink, how often they drink, things they like about drinking, their expectations, things they maybe don't like so much, like the kinds of harmful consequences they're experiencing, and trying to link those or hook those in to things that they care about, like, for example, Dr. Kilmer mentioned, nutrition, weight gain, sleep, stress, etc. Financial costs is another thing that we often do. And then talking about protective behavioral strategies. This particular feedback, actually, I used in a study that did not do an in-person BMI at all. We actually just mailed the feedback to people, and I'll talk about that in a minute as well. In-person brief motivational enhancement interventions, there's an overwhelming support for these kinds of interventions. I identified 37 randomized clinical trials over the past 10 years that met the inclusion criteria. 29 out of 37 had statistically significant effects on alcohol use, alcohol consequences, or both. Again, stronger studies with better methodology found more consistent and larger effects. 2 of 3 studies that compared individual brief motivational enhancement interventions against multi-component skills-based interventions that didn't have this feedback-based component did favor the BMI on at least some outcomes. But they're very comparable on many outcomes. A lot of the multi-component skills interventions are done in groups, whereas a lot of the brief motivational enhancement interventions are done one-to-one. So there are obvious differences besides the content that might influence the outcomes, and that hasn't been well studied yet, in my opinion. Doing a brief one-on-one motivational feedback interview with individual students is kind of expensive. It can also be challenging. You may not have the personnel or resources to do that. You may not have the training to do it. So many of us have moved toward looking at whether we can dispense with the therapist in some of these cases. And use the internet, use cell phones, use mailed feedback, et cetera, to reach students with this kind of feedback without bringing them in for a one-on-one intervention. So this is just an example of what some of our more recent web-based feedback looks like. It's interactive. Students can link to things that they get more information about if they're interested. It goes through all the same components, but in a more interactive fashion. This, for example, is a link that they get. We first show them that all of these people drink 2 drinks. And then if they are interested in knowing what does that translate to in terms of the effects of alcohol and the actual alcohol content, they can link in and they can see what those 2 drinks of Sparks is in comparison to 2 drinks of light beer. Jason Kilmer gets complete credit for coming up with this. The students benefit from this. And then again, this information is used to link them to motivational content and to skills-based content that they can use to change their drinking if they want to do so. We also give them some information about financial costs of their drinking and what else they could buy with that money if they cared to. They can link to this or not, depending on the teasers that kind of get them to this point. And then they can go from there to, well, what would I do differently in order to get those 6 nights, 6 days and 5 nights in Waikiki? I really wouldn't have to change my drinking very much. How would I go about doing that? And then they get to the tips. Some of the more recent feedback also allows them to tell us whether they're likely to use any of these tips or not. And if they're likely to use them, they can route one direction. And if they consider using them but might have questions about them, they can go another direction to get more information about overcoming barriers, etc. These kinds of standalone, either web or computerized or mailed feedback interventions also have evidence suggesting their efficacy with college students. We have come across 24 randomized clinical trials at this point looking at various iterations of this type of feedback, from the fancy to the very basic. And 19 of the 24 had some effects, statistically significant effects on drinking, on consequences, or both. One of the things I will note is that these feedback-based interventions that don't have an in-person component tend to be a little bit more associated with reductions in drinking and a little bit less associated with reductions in negative or harmful consequences of drinking. Part of that is an artifact of study design. Many of these have had shorter follow-ups, and there is some evidence to suggest that effects on harmful consequences are emergent over time. But there's also data, some of it coming from here, to suggest that in-person interventions have emergent effects on harmful consequences that outpace the effects of feedback-only interventions on harmful consequences. So as you go out farther, the in-person looks better. The effects maintain and in some cases get larger, especially on harmful consequences. So that's a research need that we have, is to see what we can do to sort of tweak those feedback-only interventions in order to increase their efficacy for effective harmful consequences. There also aren't very many studies that compare in-person to standalone interventions. I mentioned that this, personalized normative feedback or correction of misperceived drinking norms is sort of possibly a subset of these brief motivational enhancement or personalized feedback interventions. This is a growing area of research. And it's based on a fairly simple premise, that is, most people think that most people drink more than they do, and more than the person, him or herself, does. And the more you drink, the more likely you are, up to a certain point, to believe that the other person drinks more than you do. And that providing corrective feedback about accurate norms for drinking might reduce your alcohol consumption, particularly if you're a person who cares about what other people think. So this happens to be data from our campus showing that the average UW student only consumes about 5 drinks a week, and they drink about 3 drinks per drinking occasion, which is wildly less than the average student believes they drink. This is another way of looking at that, where you provide information about what they believe, what they themselves actually do, and what the actual norm is, and provide that just on a computer or on a written piece of paper, etc. There have been 8 studies that we identified in the past 10 years that have looked at normative feedback by itself as an intervention, usually on a computer. 6 of the 8 have shown efficacy on reducing drinking. Only a couple of those had demonstrable effects on negative consequences. Changes in drinking norms do mediate these effects. That is, if you can change the norm, the change in the norm is related to the change in drinking outcomes subsequently. And some of our most recent research, we had a very fancy and complicated research design looking at the extent to which getting feedback about a reference group that's closer or more similar to you would be more effective than getting information about the typical college student. We hypothesized, we actually had competing hypotheses. One set of hypotheses looked at the extent to which the similarity to you made the feedback more impactful, you believed it more, and were more likely to have bigger changes in your drinking. The alternative competing hypothesis looks at the magnitude of discrepancy between your drinking and whatever norm you got, because obviously the norm varies depending on the population that you're giving the norm for. We found that for the heaviest drinkers, magnitude of the discrepancy outweighs salience of the normative referent group by far. So getting generic, typical student feedback, which was the lowest norm for those groups that were heavier drinkers, was associated with larger and more reliable changes in drinking than getting feedback about somebody who was very similar to you. However, one study by Melissa Lewis has suggested that more specific reference groups might be more effective for women. So for women, getting feedback about other women is associated to a certain extent with more impact on their drinking if they are strongly identified as a woman. So it kind of matters who you care about as well as what norm you get and what your own personal characteristics are. We also find that heavier drinkers and men tend to see themselves as more similar to the typical student. So that if you ask them who is the typical student, it's a heavy drinking man who's white. So that might give you some reasons also why typical student feedback works as well or better than specific. I don't have to say much about alcohol expectancy challenge because Mark already talked about that, but just briefly, a lot of this research has looked at experiential or in vivo alcohol expectancy challenge. That's bringing people into an experimental drinking laboratory where they're given a drink, they're asked to interact with others, they're asked to judge whether they got alcohol or didn't and whether the other people that they're interacting with got alcohol or didn't. People are notoriously bad at this. They can't tell you whether they got alcohol, and they can't very well tell you whether other people did either. And that has been related to reductions in their drinking after having undergone one of those experiences. There's less support for sort of didactic or discussion-oriented expectancy challenge, although it is typically a component in these multi-component brief interventions. So of the studies we reviewed that included either a didactic or an experiential alcohol expectancy challenge as a primary component of the intervention, about half showed impacts on drinking. And I would concur with what Mark said, is that the most interesting thing is to understand when it does and when it doesn't. And I think that's a very fruitful avenue for future research. And then the other thing I'll just mention is that we have looked at special populations, including effects with women, with medical patients, with athletes. I know Matt's going to talk about athletes tomorrow, so I'm not going to say much about that. But one of the areas where there's been the most development in the last 10 years is looking at interventions that are effective with mandated students or judicially, people who have violated alcohol policy. I think that the results of this are extremely encouraging. So at this point, when I did the first review, there was one study that met inclusion criteria for mandated students. It was an informational approach. It did not work. There are now 14 randomized controlled trials with mandated students that met inclusion criteria, and 10 of 14 had demonstrated effects on drinking consequences or both. The vast majority of these are brief motivational interventions or multi-component skills interventions. So if you take interventions that are based on all that science base that you heard about this morning, about what is it that predicts drinking, what's related to drinking, how about norms, how about expectations, et cetera. If you take interventions that map onto those predictors and you implement them as they're intended to be implemented, you can produce reliable impacts on student drinking. So just to look backward and to look forward, as I started with, there have been important and really encouraging developments in the field over the past 25 years. There really is overwhelming support for these brief motivational and skills-based interventions in reducing drinking and, to a lesser extent, harmful consequences. They've been done in high-risk populations, in low-risk populations. The study that I mentioned that used mailed feedback was a universal prevention. We just sent it to every freshman in the incoming class. Actually, our biggest effects were on maintenance of abstinence, followed by reductions in heavy drinking. There is less consistency in changing consequences than in changing drinking per se, but this may have to do with the length of follow-up and that harmful consequences take longer to appear. It may also have to do with what we're, if we target drinking, we change drinking, but there are a lot of things that influence consequences besides how much you drank, as you just heard from Kim, for example, and as we've talked about in terms of some of the contextual factors that influence harmful consequences. So I think we really have more work to do there. And most of these effects are small, at best moderate. We make changes. We make changes that are reliable, but they are not large. I think some of the work that we have to do is in increasing the reach and access to these programs. You heard from Dr. Kilmer this morning that most students who would benefit from such interventions never receive them. And some of that has to do with what we understand about how much is enough, what materials you need, what resources you need, what training you need in order to do these interventions effectively, and how we can get that into the hands of practitioners. We need to do further evaluation of these, sort of low threshold web, mailed, cell phone interventions to look at how we can enhance those. And then we need to look at distribution systems. I mean, there are commercial products that are widely available and widely utilized, but have been relatively understudied. And there are these, bells and whistles, tightly controlled, well, designed, randomized clinical trials that don't have materials to go out to practitioners in order to use them. Guilty as charged. So, so I think that's where we really need to spend a lot of our attention in the next 5 to 10 years, is really developing those distribution systems, and whether that's by working with people who have got the distribution systems, or whether it's some kind of national distribution system for these interventions. I think that's an important direction to go. I think increasing the effects of these interventions. Field is now moving toward dismantling studies, looking at those components like the normative feedback by itself, like protective behavioral strategies by itself, expectancy challenge by itself, and really looking at what can we do to strengthen each of those individual components as much as we can, such that when we put the package back together, it has a larger effect. As well as understanding when and for whom these kinds of interventions are most effective. Maybe it's in the transition when they're coming out of high school, taking advantage of that natural teaching opportunity. Maybe it's when they're already in college and things have more reality for them, such that if you're talking about it a year before, they don't really understand what they're getting into, and they're kind of like, yeah, but now they've experienced it, you can really make more change. We don't know for whom and when. Event-specific kinds of interventions is another place where that, I think, really matters, like moving toward looking at 21st birthday interventions. Kim mentioned this. Clayton Neighbors has done this work as well. Christine Lee is looking at spring break interventions right now, looking at this particular high-risk period of time and whether we can reduce the harm at that point in time. And then looking at how these interventions fit in the overall context of the kinds of environmental prevention approaches that I think Bob Saltz is going to talk about tomorrow. And using parents. I mean, as a parent, I like to think parents matter. And some of our data suggests that they do matter. They're a highly credible source of information, but we really don't do enough to impact, how they communicate with their students. Addressing comorbidity is a direction the field is moving. Jason talked this morning about the very high rates of comorbidity. He also talked about how that's a hook for people. Students are not going to come in necessarily voluntarily to talk to you about their drinking, but they will come in to talk to you about their stress, their sleep, their depression. One of our graduate students at University of Washington, Ursula Whiteside, just recently completed her dissertation funded by NIAAA as an NRSA, looking at a randomized controlled trial combining the basics intervention with distress tolerance skills from dialectical behavior therapy for students who have comorbid anxiety or depression. She found actually both interventions were more effective than control, but the combined intervention was more effective for reducing both anxiety and depression symptoms and alcohol use and related negative consequences. And it didn't take any longer, and students loved it. So that's a direction to move. And then developing systematic approaches to adapting and evaluating these kinds of evidence-based interventions. We know people are going to adapt these interventions. They have to. We did not design them to be appropriate in every context. We're recently starting to do some work. A colleague of mine at the UW, Bonnie Duran, and I have started to do some work with some of the tribal colleges and universities. Completely underserved, not involved in the vast majority of the research that has been done looking at, the development of these interventions. One of the faculty members there that I talked to, she's a full professor. She runs a couple of the scientific major programs of the college. She makes $42,000 a year, and 3 days a week she drives the bus to bring students onto campus. I mean, the resource needs there are unbelievable, and they're not going to come up with bells and whistles, basics type interventions that are going to be able to be implemented. So coming up with a system for doing that adaptation with more foresight in advance, rather than just kind of throwing it out and letting people experiment with it, I think would be a helpful direction for us to move. So, I mean, I think that those are some directions I see the field moving, but there are a tremendous number of resources available right now. And I would suggest as a starting point that you go to www.collegedrinkingprevention.gov, and from there you link to the NIAAA homepage and look at the wealth of resources that are available. And I thank you.